Hello and welcome to today's Center for Healthcare Strategies webinar made possible by the Gordon and Betty Moore Foundation on addressing medication complexity through innovative community-based strategies and partnerships. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 2 moderated question and answer sessions following the main presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. The slides and recording will also be emailed to all participants after the webinar. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Bianca Freda, Program Officer at the Center for Healthcare Strategies.
Thanks, Travis, and welcome everyone. We are pleased to have you join us for today's webinar on addressing medication complexity through innovative community-based strategies and partnerships. Before we get started, I'd like to thank the Gordon and Betty Moore Foundation for their support of this project, the Community Management of Medication Complexity Innovation Lab. And now I'd like to introduce our 2 excellent speakers. Carrie Trapkin is Vice President of Healthcare Quality Initiatives for the Pharmacy Society of Wisconsin and has coordinated the Wisconsin Pharmacy Quality Collaborative, or WPQC, Medication Therapy Management Program since 2006. She was co-principal for the WPQC CMS Healthcare Innovations Award between 2012 and 2015. Carrie earned her BS in Pharmacy and PharmD degrees from the University of Wisconsin School of Pharmacy, and following a residency, practiced as an inpatient pharmacist in Lexington, Kentucky, and as a community pharmacist in Madison, Wisconsin. Carrie was awarded the University of Wisconsin-Madison Young Pharmacy Alumnus of the Year Award in 2014, and the inaugural Community Pharmacy Innovation and Quality Award in 2018 by the Pharmacy Quality Alliance and Community Pharmacy Foundation. I'm pleased to also welcome our other speaker, Dr. Mike Wolf. Mike is a health services researcher with expertise in health literacy, aging, chronic disease self-management specific to medication safety and adherence, and the design of health system interventions to promote health. He has led numerous federal, private foundation, and industry-sponsored studies investigating determinants of health services use and outcomes, and interventions aimed at helping patients better engage in self-care tasks beyond the point of care. In 2004, Mike founded the Health Literacy and Learning Program, or HELP for short, at Northwestern University. Since 2009, he has also served as Associate Division Chief for General Internal Medicine and Geriatrics at Northwestern, and in 2014 was appointed Associate Vice Chair for Research for the Department of Medicine, with a goal to catalyze health services research across all clinical divisions. Next, I'd like to review today's webinar agenda. First, I'll provide a brief overview of the Community Management of Medication Complexity Innovation Lab. Then I'll turn it over to Carrie to present her slides on optimizing a statewide medication therapy management program in Wisconsin, followed by a question and answer period where all of you participating in the webinar can submit questions you have for Carrie. Then we'll turn things over to Mike, and he'll give his presentation on simplifying complex medication regimens using the Universal Medication Schedule. And we'll close with another moderated Q&A session with the speakers. So let's get started. There are a few goals of the Community Management of Medication Complexity Innovation Lab that Carrie, Mike, and their teams are participating in. This is a 2-year initiative supported by the Moore Foundation that's funding 5 sites as they test and implement various community-based interventions. The goals include identifying and advancing effective community-based strategies to address medication complexity, supporting opportunities to expand, refine, spread, and scale promising models to other healthcare settings, and lastly, improving patient experience and empowering individuals with complex medical, behavioral health, and social needs so they can effectively manage their medication regimens. Next, Here's an overview of the 5 sites that are participating in the Innovation Lab, 2 of which are with us today presenting. First, Northwestern University is partnering with Health Lab and Oak Street Health to implement the Universal Medication Schedule, and you'll hear much more about that from Mike later in this webinar. We also have the Pharmacy Society of Wisconsin, who's with us today. They're providing training to pharmacies to implement CMRs and final product verification using pharmacy technicians to dispense medications and freeing up pharmacists for other services. ThedaCare is partnering with community pharmacies and implementing a medication risk score within the EMR and deploying multidisciplinary care teams. Towncrest is using prescriptions and claims data and assessing patients' social determinants of health to identify and intervene with high-risk patients. And finally, the University of Minnesota is partnering with Fairview Health Services to provide comprehensive medication management to behavioral health patients and understand their social determinants of health matched to medication therapy problems in an effort to optimize medications and prevent readmissions. With that, I am pleased to now turn it over to Carrie Trapkin. Carrie?
Thanks, Bianca. This is Carrie. Let me just get the screen here. So as Bianca mentioned, I will be talking today about optimization of a statewide medication therapy management program. I am employed at the Pharmacy Society of Wisconsin, or PSW. The Pharmacy Society of Wisconsin is a state professional association for pharmacists, pharmacy technicians, and pharmacy students from all practice settings in Wisconsin. Our mission is threefold: to provide education, practice advancement, and advocacy for our 4,000 members statewide. So today I'll be describing PSW's Community Management of Medication Complexity project that is aimed to increase comprehensive medication reviews, or CMRs, for Wisconsin Medicaid members by addressing barriers to CMR provision that we have learned throughout our previous work. So first, what is WPQC, or the Wisconsin Pharmacy Quality Collaborative? WPQC is a network of pharmacies with certified pharmacists providing medication therapy management, or MTM services, such as comprehensive medication reviews to patients. PSW accredits WPQC pharmacies based on a set of 7 quality-based best practices focused on decreasing medication errors and improving safety. WPQC was built from the ground up via payer-pharmacist collaboration over 10 years ago. We have established partnerships throughout the process that have allowed this work to continue and flourish. Though the healthcare landscape has changed, we've adjusted with it, but the premise has been the same, that pharmacists in the community setting are an essential part of the healthcare team and can provide unique medication-focused services to patients with complex medication regimens. These complex medication regimens are a risk factor for hospitalizations and decreased morbidity, and sometimes even increased mortality. The comprehensive medication review is one component of medication therapy management. WPQC comprehensive medication reviews are high-level services very comparable to another service name you may have heard, the Comprehensive Medication Management Service, or CMM. Comprehensive medication review services are provided by the pharmacist via a sit-down appointment, which typically lasts between 45 and 60 minutes. The goal of the CMR is to identify, resolve, and prevent medication-related problems. This CMR can be provided by the community pharmacist or the pharmacist embedded in the clinic setting. Medication-related problems can be related to medication cost, more appropriate dose or dosage forms, duration of therapy, need for in-depth medication device instruction, need for additional medications based on gaps in care or evidence-based clinical guidelines, or the need for discontinuation of medications that may not be appropriate for a specific patient. Problems with medication adherence or taking medications as intended also can be in that list of medication-related problems. Upon completion of the comprehensive med review, the pharmacist communicates their findings and recommendations to the patient's healthcare provider for their review and approval. The patient also receives detailed documentation from the Comprehensive Medication Review in the form of their personal medication record and medication action plan. So though WPQC is a unique program, like all states, we have had our share of challenges in use of the program. Our main barriers have been time, patient acceptance, or showing up for the visits, and marketing. In order to address these barriers, we decided to train 8 pharmacies on optimal technical workflows, specifically by training and validating pharmacy technicians to provide final drug product verification, along with holding comprehensive medication review coaching work groups. The goal was to increase workflow efficiency in the pharmacy and therefore increase the amount of time pharmacists were able to spend in providing comprehensive medication review services for Medicaid members. Our main outcome measure is an increase in comprehensive medication review services being provided. We have also provided marketing support and 2 rounds of site visits to participating pharmacies focused on supporting implementation of the final product verification workflow and implementation of comprehensive medication review services. The site visits have been separated by approximately 9 months. When optimal workflows are used, pharmacists are able to spend more time with patients providing direct care. This is possible by better leveraging pharmacy technicians to complete the technical task of final product verification that does not require clinical expertise. Decades of research demonstrate that these tasks may be completed safely and correctly by pharmacy technicians rather than by pharmacists, which frees up the pharmacist to provide care at the top of their license. These services include providing CMRs to patients to reduce their medication complexity. The WPQC program provides certified pharmacists the ability to identify and perform CMR services for eligible patients. Eligibility requirements include 4 or more prescription medications to treat or prevent 2 or more chronic conditions, of which hypertension, asthma, diabetes, chronic kidney disease, heart failure, dyslipidemia, COPD, or depression are among the list. Diabetes, coordination of care due to multiple providers, discharge from the hospital or long-term care setting within the last 14 days, low health literacy, or physician referral. And our current participating payers include the Wisconsin Medicaid program, or Forward Health, United Way of Dane County for their program looking at falls and adverse drug events in older adults, as well as NewGen, formerly known as WEA Trust. The WPQC program allows each patient to receive 1 initial and 3 follow-up comprehensive medication review visits per rolling year. If additional services are warranted, the pharmacist is required to receive prior authorization from the payer to provide these additional services. Patients can also receive a CMR after each discharge from the hospital or long-term care facility. This is in part due to the complexity of transitioning patients via focused medication reconciliation following discharge from the hospital or long-term care facility. These comprehensive medication reviews are individual interventions and are not expected to follow the typical initial and follow-up visit structure. As PSW, we require pharmacists in order to be certified in WPQC to complete a 12-hour continuing education WPQC home study. The home study includes components of motivational interviewing and health literacy, 13 chronic disease-focused clinical toolkits, and the logistics of the program. We also support pharmacies and pharmacists by providing comprehensive medication review coaching work groups that are done via the phone, on-demand webinars, and pertinent conferences. As part of our work through the Center for Healthcare Strategies, we conducted a baseline pharmacist perception survey. You can see that both time and marketing emerged with the highest perception of insufficiency for the program at baseline. These aligned very nicely with what we had set as our goals to impact for this program, both time and marketing. One of our goals was to increase comprehensive medication review services provided by all WPQC pharmacies, not just the 8 that we had targeted for the final product verification and work group intervention. Based on Medicaid utilization data, we showed an increase in pharmacies that completed at least one CMR between the start of the program in May 2018 and January 2019. That increase was 58%, which was above our goal of 15%. We continue our analysis around this and other metrics that we are targeting. This slide shows the current utilization data for our comprehensive medication review services that have been provided for Wisconsin Medicaid members. You see, since the beginning of the program, we have provided almost 10,000 comprehensive medication review services, broken down into approximately 70% of them as initial and 30% as follow-up. As mentioned, we have dedicated a good amount of time to helping pharmacists market their comprehensive medication review services. In this picture, you will see a WPQC pharmacist from Milwaukee providing a home visit to a Rohingya refugee covered by Wisconsin Medicaid. This is a service that is compensated for by Wisconsin Medicaid. This photo was obtained during a site visit in preparation for several videos we created to show how WPQC pharmacies are serving the underserved. A similar story was coordinated through this work and covered on a main Milwaukee news channel as a special interest story. We're now able to use these and other videos and stories to promote pharmacy services like CMRs to diverse audiences. An additional marketing strategy that we used was to provide education on how to interact with multiple forms of media and how to tell the pharmacy's story. By empowering pharmacists in our coaching work group sessions to tell their stories and guiding them along the way, we hope to continue to expand the demand and knowledge about services that pharmacists can provide in order to address medication complexity. So our main challenges and discoveries related to an unanticipated closing of a fairly large corporate pharmacy in the middle of this work. This overwhelmed a couple of pharmacies in our group with transferred prescriptions and impacted their time to spend on full implementation of the final product verification workflow and their progress with CMR implementation. There is, though, excitement and commitment from these couple of pharmacies to continue the work as things settle down in their practices. Additionally, certain pharmacies found out that the workflow changes for implementing final product verification required more lengthy changes to software to implement, which slowed the process slightly for some. Overall, however, the process of final product verification implementation has gone smoothly, and pharmacies are very pleased with the results and the time that they have gained that is being reallocated to providing patient care services. And last, marketing needs. We found out through the process of providing coaching work groups and special marketing training that in addition to comprehensive medication review marketing opportunities, that pharmacies also needed help marketing their unique approaches to providing medication adherence services and support to their patients. We have pivoted a bit and are currently providing additional focus to adherence in addition to comprehensive medication review marketing. So with that, I would like to thank the Center for Healthcare Strategies and the Gordon and Betty Moore Foundation for their support of this unique project and opportunity to participate in the community management of medication complexity work. Back to you, Bianca.
Thanks so much, Carrie, for that excellent presentation. And as the questions roll in, just as a reminder to submit a question, please click on the Q&A icon at the bottom of your screen. And so here's the first question, Carrie. You talked about payer participation in one of your slides. We know it can be challenging to obtain coverage for enhanced pharmacy services like CMRs. How did this come about in Wisconsin that Medicaid pays for these services?
Yeah, thanks for the question, Bianca. So going way back, and we've been at this for quite a few years now, we had our board decided that we wanted to work together, as I mentioned, collaboratively with partners. And so we actually brought folks together around our table here from multiple different organizations multiple different payer organizations, and along with pharmacies, and we developed the program together. Medicaid was at the table with us at that point in time. So the program was actually developed with Medicaid's input. It did take several years to get to the point where we were actually implementing the program with Medicaid. We had regular communication. They were part of our steering committee. And currently, now that they are part of our work and a participating payer, we have regular communication every month via phone calls, as well as we did have to go through a process to develop a state plan amendment to our current Medicaid language.
Great, thank you. And this is sort of a follow-up related question. How are Wisconsin pharmacists reimbursed for these services, and is there a set rate?
Yeah, so that information is publicly available, and those rates were set by the State Department of Health Services. So they are reimbursed flat amounts for the initial and the follow-up services. Those are available online. They are I could follow up with that person at the end if you want to get the information. They're approximately half for the comprehensive medication review follow-up as compared to the comprehensive medication review initial service.
Great, thanks so much. A different question. Did you find that language barriers are another deterrent to CMRs?
Absolutely. That's a great question. You saw the marketing slide where we showed the Rohingya refugee family that does not speak English. That specific pharmacy that we communicate on a regular basis with and is providing a good number of comprehensive medication reviews actually represents about 18 different languages that they provide translation for. So I definitely think that language barriers are challenging. We have ways that people are getting around that pharmacy in particular. That plays into health literacy, obviously, but definitely language barriers are a problem, but people are using different means to overcome that.
Thank you. This is a two-part question. How do pharmacies that are providing CMR communicate with primary care providers? And what are some of the strategies you've used to overcome primary care providers' reluctance to have pharmacists working with them?
That is also a very good question. So currently, the pharmacies that are not affiliated with a health system, a lot of them have access to the Epic EMR via like a read-only CareLink process. And so that doesn't allow communication back and forth, but it does allow view into the electronic medical record. That communication is typically communicated via fax, where they fax the information back to the primary care provider. If the pharmacy is in a health system, then typically they're actually documenting an encounter right in the EMR that gets sent back to the physician that way. And then the second part of the question was strategies to overcome PCP reluctance to partner. And so we've, as a collaborative, we've provided a lot of information, toolkits, strategies for how to market your services, how to communicate, how to partner with groups in your community. And that's kind of the way that we've tried to approach that. And also really talking about team-based care and positioning the pharmacist as a collaborator that's contributing to care versus trying to take over care, because that's not the case at all. It's really just trying to enhance the care that patients are already receiving.
Thanks. Next question. Does Wisconsin have pharmacist to pharmacy tech ratio requirements?
We do, and that is, I think it's actually in process of being changed. I could get back to you on the specifics of that.
No problem. We can send that out after the webinar. Then a follow-up question is, are there certification or licensure requirements from the Wisconsin Board of Pharmacy for pharmacy techs to engage in enhanced distributive functions?
There are, and I can also provide that information as a follow-up too. So the technicians go through a validated process in order to engage in these activities.
Great. Here's another question. What outcomes are the payers interested in seeing in order to agree to pay for the services?
That is a great question as well. All good questions today. As you can imagine, of course, cost savings, longer term healthcare outcomes, decreased hospitalizations, decreased ER visits. But then in the short term, some of the groups are just really focused on how can we engage patients more and do better than sometimes the current status is with some of the care management programs internally. So we've kind of had across the board, it's pretty hard to show in a short period of time those long-term healthcare outcomes, though our work with the state Medicaid program has been a bit promising in terms of the acuity and the cost of care for patients in the hospital that have gotten comprehensive medication reviews versus those in a comparison group that have not gotten comprehensive medication reviews. So there's some potential there that there's some cost savings related to that at this point in time.
Thanks, Carrie. So you had some pretty impressive results that you presented to us. What do you attribute those results of a 58% increase in CMRs across all WPQC pharmacies when your goal was an increase of just 15%?
Yeah, so we've been very happy with that increase, and hopefully we'll have an even higher increase as we collect the last few months of data here and analyze those. I think the combination of using the final product verification and freeing up the time of the pharmacist by utilizing technicians more has definitely had an impact on that. We also spent a good bit of energy and work developing the relationships with our pharmacists over time in the pharmacies, and then that's allowed us to focus on marketing. So we had a goal of reaching 10,000 comprehensive medication reviews this year. And we have done that, and we made sort of a big marketing deal out of that. We have also been using all of our own marketing outlets to promote that, and just really had a focus on this program. So, but I do believe that the final product verification has a lot of potential, and that we've made good strides there, and seen a lot of sort of a lot of more energy.
Great. Here's a question. Is there a difference in effectiveness between CMR pharmacies that are embedded in health systems versus ones that are not?
Well, I think the kind of the obvious answer to that is just that there's some fewer barriers that are present for those embedded for pharmacists embedded in clinics versus in the community setting. Just namely being that they're right there typically when the patient is getting their clinic visit or being referred by the primary care provider to see a patient specifically for XYZ condition, and that they typically have access to the EMR and can document within. That being said, I think the community setting also has access to cost data and is seeing the patient on a regular basis in terms of their adherence. And does have most of the time now access to the EMR in a read-only fashion. So I think there's positives and negatives to both sides, and probably the best answer is for everybody to work together and be able to communicate between both settings. I think you also get different just expectations for the community setting, because the community setting, patients aren't expecting that they're going to go to a community pharmacy and receive a higher level service there. We do have pharmacies that are providing home visits, and that's becoming a little bit more common. And so that's really trying to meet the patients where they're at, which is something that can't really be done in the health system. So I think there's advantages and disadvantages to both, and barriers to both, and good things to both. But you're probably accurate in terms of the ability to actually be able to see the patients, and the patients to show up in the clinic setting is definitely an advantage.
Okay. Next question, what approaches have been successful in engaging patients in receiving enhanced services from pharmacists?
Yeah, that's also another good question, not with a 100% answer for you, but in terms of engaging patients, I think community pharmacists in general do have a good relationship already with their patients. Some of them, and we always encourage pharmacists not just running a program by themselves, trying to engage all of their staff. So, utilizing their technicians and their other support staff to try to engage patients in the program if somebody's complaining about how they're overwhelmed with their costs and with their conditions, to refer them sort of within the same system. Another approach that's been really successful is community outreach. So we work with the United Way of Dane County, and that is related to falls and adverse drug events in the older adult population. We bring pharmacists out to community centers and senior centers and do comprehensive medication reviews, set up as a clinic, really, for lack of a better word. So, having the case managers and folks who are seeing the patients out in the community and know which patients need help, that has been really helpful as well, to provide care where it's needed. And that's really helpful when there's another trusted community source that's engaging patients.
Okay, thanks for that. So this may or may not be something you're tracking, but this question was around how many errors have occurred during this program or pilot. Might be referring to pharmacy text, but didn't specify.
That could also be something that I could follow up. I'm guessing it's related to the final product verification question there. Very, very low rates, and data has shown that that technicians may actually be more accurate than pharmacists in that regard, probably because they're more focused on one task versus thinking about a lot of the other clinical things that pharmacists are thinking about. So whoever asked that question, if you want to put your information or get it in touch with Bianca, we can talk further about that, but very low.
Great, appreciate that, Carrie. So thanks for that round of Q&A. We're going to give you a break now, and we'll have more time for questions at the end of the webinar. So now I'd like to turn it over to Mike Wolf for his presentation. Mike?
Great, thank you very much. And that was a great presentation, Carrie. And there's going to be some, I think, nice tie-ins with what you've just kind of covered. So on a more myopic dive into the rabbit hole of a very specific aspect of pharmacy practice and actually clinical practices is what I'm going to be talking about with talking about simplifying complex medication regimens with what we've been working on over the past, it's been 13 years now since we first just kind of coined the term the Universal Medication Schedule, or what we call the UMS, which is part of our project with the Center for Healthcare Strategies. And it started off as a very small idea that really kind of reverberated around many aspects of from the point of prescribing through dispensing that I'm going to talk about today. So oops, I'm just going to first talk about the group at Northwestern University that I founded the lab in 2004, which is the Health Literacy and Learning Program, or HELP. Our focus has really been around the design of effective, scalable health system-based strategies. And initially, it was more broadly focused on just patient chronic disease self-management, but then it has since kind of evolved into a very much of a deep dive into helping patients safely use prescription medications. And really, it even kind of became most focused on an older patient population, those who are most likely to be taking not just one, but oftentimes a number of medications throughout the day that they've had to manage, which put them at both elevated risk for both making adverse drug events or other medication errors, or also just inadequate adherence to the regimens to not optimally benefit from their treatments. And the interesting aspect that we as a lab have been focused on is this confluence of really two age-related issues that kind of clash in the later years, which is again, 80% of adults over 65 live with 2 or more chronic conditions. That actually, in the multimorbidity sense, over 2/3 are living with 3 or more chronic conditions, and nearly all patients over 65, or 90%, are having at least one condition that they have to manage. And all of this requires complex chronic care, seeing one or more clinicians 1 or more times a year to manage it. But at this very time where you have more chronic healthcare issues that are starting to materialize that lead to more prescription medications, is really also the age trajectory of cognitive decline, where we also recognize that people process information a little bit slower, multitasking becomes more challenging, as well as other sensory issues like visual acuity that really increase the burden of managing self-care tasks effectively. And that's what we're really geared towards. Trying to simplify behaviors. And the reason I think our lab has spent so much time focused on medication use, and specifically polypharmacy, and for this case, the most common definition of polypharmacy, for I'm sure many people on the line today are aware, is really kind of 5 or more medications is where we draw the line, is where it becomes more complicated and the potential for error increases. And from a patient perspective, really starting to take a deep dive at what does it mean to have to be taking all these medications. It can be very, very complicated, and unnecessarily so when we think about how patients get their medications. We see a larger uptake in the number of patients who are taking using more than one pharmacy, and that oftentimes was attributed to the onset of electronic prescribing, where it became much easier to actually incorporate multiple pharmacies into the medical record, and people would be choosing between whether they want to fill their prescription at the pharmacy near their work or near their home, or using mail order right now. And ultimately, all these medications, and what happens when patients get their labels, these things aren't necessarily coordinated well, and patients themselves have the challenge of having to kind of dissect and understand and organize and schedule out their medications, and oftentimes not in the most effective manner. And we had some, just thinking about just how dynamic the behavior of taking medication is. And again, this is where it's down the rabbit hole a bit in terms of really understanding why do people struggle so much with taking their medications, especially if they've got multiple medications to take. And when you think about the behavior, and also specifically on how the healthcare system imparts the behavior to patients and their families, it's kind of understandable why it's a struggle to manage these medicines every day, and why we wanted to pitch this idea of a universal medication schedule, which I'll be talking about in just a moment. Is first off, it's dynamic in the sense that taking medication requires a regimen that oftentimes you're adding or changing or removing medication. You've got these multi-drug regimens with variable doses that require patients to kind of do the math and figuring out when they should be taking and spacing out a twice daily or a 3 times daily medication. The medicine also might be dispensed in different modalities, so it could be a pill or an injection or an inhaler, et cetera. Sometimes you have medications that kind of come in with tapered and escalating doses, so it's not just a consistent pattern over time. And then you have doses that are dependent on measurement, whether it be for heart failure or for diabetes. And then you have the daily and non-daily medications, or pro re nata as needed medications that make guest appearances in your regimen. And those that, again, often may be limited duration, like antibiotics and so forth, that patients have to know how to organize and take their medicines that way. Then with multiple prescribers and multiple pharmacies and variable instructions that don't necessarily align with how they're supposed to space their medication or what medication can be taken with the other, if some come with food restrictions or other dietary requirements. That becomes challenging. And then on top of it, what also makes it more dynamic is the notion of brand versus generic drugs, where the trade dress or the look and the color and the shape of the pill, all of that can vary depending on if a manufacturer is switched in the middle of their medications. And then on top of it all, we hear a lot from patients too, that the fact that prescriptions are oftentimes unsynchronized, so patients, the burden of having to take medication also means that they're oftentimes going multiple times a month to fill prescriptions, which also adds burden and also delays and oftentimes with patients not having medication. And so with that, we sought to kind of figure out how could we at least contribute some support to patients to simplify this behavior to the degree that we could. And our lab, as in its title, has really been about promoting health literacy. And while the definition you can see here really reflects the cognitive and social skills, which determine one's ability to kind of access, use, and understand and health information to make informed decisions. And you can see the different aspects, of course, that patients really need to kind of have a lot of cognitive skills, whether it be reading or numeracy or memory or other kind of problem-solving activities that we would like to think ultimately contribute to optimal self-care. Health literacy is really a reflection also of the adequacy and the simplicity or the complexity of a healthcare system. Basically, we like to say that how well someone performs on the test is not only just on their knowledge and their ability to take the test, but it's oftentimes the nature and complexity of the items and the test itself. And oftentimes we find that healthcare systems are often unnecessarily complicated. Our conceptual framework then, which we've been focused on for many years and what led to the universal medication schedule, really is about reducing treatment burden. So to the degree that someone is not just contending with the symptoms of their health, of their chronic diseases and so forth, but when they're taking multi-drug regimens, how can we actually support that task so it doesn't require such cognitive demands that patients must have to really problem solve and sustain a behavior like taking medication. And as a colleague of mine who used to be the drug therapy editor for the New England Journal of Medicine, I've always liked to say that this is really about confusing people less and really making prescribing medication and onboarding adults onto new regimens as basic as it can be, and also to do it in a very standardized way, which we have seen in prior studies that we have worked on over the past decade and a half, that our healthcare system and the way we specifically impart medication instructions and information is oftentimes very, very complicated. And a lot of what we're looking at, again, as I mentioned about treatment burden is, when you think about just the experience of an individual and an older individual in particular who's dealing with not just one, but oftentimes multiple chronic conditions, you've got the burden of disease that impacts their ability to take medication, both physically and mentally, as well as cognitively. A lot of these medications, especially if they haven't optimally managed their disease, especially if it's a vascular one, may be impacting their how they think, how they remember, how they're able to kind of properly organize and use their medication. But then treatment burden alone also kind of really complicates their behaviors when they have to navigate between multiple healthcare providers, have frequent visits, again, having to kind of fill and maintain a multi-drug regimen that oftentimes is complicated, contend with medical devices and other technologies which we're now imparting through like electronic health record patient portals and so forth. All of this ultimately leads to a very, very difficult and complicated patient role. And I think with this CHCS initiative that we've been working with all these great partners, it's been very much focused on how do we help people in the community dealing with this very, very complicated behavior be a little bit more successful by redesigning and rethinking how we deliver healthcare. So right now, the project I'm going to be talking about really involves both Northwestern Medicine, where our lab is residing, and a wonderful community partner that through this project, we've been able to kind of really become their first kind of collaborator in terms of an applied research activity, and that's Oak Street Health. They are a primary care organization that started in Chicago with a number of clinics, and it has since expanded to Indiana, to Michigan, and they're actually also in the out east now as well, with clinics that have just opened up in Philadelphia and now also in Rhode Island. And really, let me get back then to actually just saying what actually is the, what is exactly the Universal Medication Schedule. So the UMS, as I'm going to call it, really is about this notion of standardizing the way we prescribe medication. And it's as basic as saying, can we apply a pill box schema, you know, morning, noon, evening, and bedtime to the way we prescribe medication. And again, we introduced this in 2006 with an Institute of Medicine, which is now the National Academy of Medicine. And it's just a very simple way of saying, can you just prescribe it in these terms and then ultimately dispense it so it ends up in the pill bottle so patients can ultimately organize their medicines. Real quickly, you can see that using this more explicit guidance rather than twice daily or every 12 hours or every 8 hours, or even more explicitly like 8 a.m. and 5 p.m., which doesn't really resonate with how people actually take medicine. This has been found to be a more effective way to help patients better understand how to take not just one, but multiple medications. And it's even shown in a recent project that we've done that led to working with this project with Center for Healthcare Strategies, is with the Walgreens. We've found that it benefits everybody, but specifically it helps people who have low health literacy, who are taking multiple medications, especially those that are multi-daily medications, and also older adults. We've seen increases as much as 14% improved adherence. And with Walgreens, this also led to, I think they did the math, that it came out to about, on average, for even 14 classes of medications only, where we focused on, it improved, it sold, increased about 56,000 scripts in terms of additional scripts sold. Yet it's not a common practice. As you can see, only 1 in 8 prescriptions really use this type of language in them when we looked at about 1 million prescriptions from our partner with Walgreens. So the idea, though, is starting with just at the very basic with what we're doing with Oak Street is we're looking at, one, how do we improve a medication record? So in the medication list with their electronic health record, which is not something like Epic or Cerner, it's actually something known as Greenway. But we want to be able to show that it doesn't make a difference what the EHR is. We've already done this in Epic, we've done this in Cerner, we've done this in GE Centricity, and now we're working with a community partner that predominantly serves Medicare and dual eligible patients with multimorbidity, and we're helping them reprogram their medication list so it does organize their medications using the UMS. It also embeds the default prescriptions that for when patients write will actually have the default will be the UMS instruction. So instead of it saying take 1 pill or 1 tablet by mouth twice daily, it'll actually have a default recommended prescription. We've shown that about over 90% of prescriptions usually just ultimately just order whatever the default is. So this is going to be a nice nudge to get physicians to not affect their current practices, but just if they're going to use the default, have it shoot out to the UMS. You know, just some other things that I think this coordinates well with, if anybody has seen CBS, we had worked, or I personally had worked with the designer of the label that had just recently coming out where they had put the UMS on the side. So the idea is, as a coordinated system, if we can get at the point of prescribing, helping patients learn how to start organizing their medicines so they're more likely to be able to sustain the behavior over time by now simplifying it so they're not taking medication more times throughout the day. And we, on top of that, what we're also doing is, as a kind of a supplement at the request of Oak Street, is we're also being able to link. We have created now plain language, low literacy, also bilingual medication sheets that can be generated. They automatically queue up as a JPEG picture file. And when you sign the order, it automatically deposits it in the after visit summary so it doesn't break across pages. But that means patients leave the point of prescribing with good, actionable information about their medication, which really not waiting for them to go to the pharmacy and get the material stapled to the bag. And this is also an evidence-based approach. And these are publicly available as well that we can provide to anybody at no cost if there was any interest in this library. So again, we're working with Oak Street, just in the Chicago-based aspect of their practices for a local kind of build. Again, 50% of patients are dually eligible for Medicaid and Medicare. It's a value-based managed care model. They assume full risk for their patients. And so it really is a great partnership. And I think the sell for them was that anything that can do to help them optimize in their management of their chronic conditions through taking the medications more effectively, that this could be something, especially since it's a seemingly low cost set of tools that we're providing. With the CMMC, we're actually piloting it. Again, it's already been built now in Greenway. It's being piloted as right now, as we speak. We've managed to do the build and actually expand on what we even proposed to be doing by creating a kind of a medication list that will automatically deposit and populate that UMS table that you saw in the grid. By just them ordering the medications, it converts the medication SIG to correspond with the morning, noon, evening, bedtime buckets. And the goal right now is, again, doing structured interviews with about 70 patients, with the primary outcomes really being fidelity. That can we assume by doing this at the point of prescribing and automated it, can we actually make this land appropriately onto the patient's prescription pill bottle? So all of a sudden, patients will now have less variable, more standardized, and more patient-friendly and explicit instructions on when to take medicine. Finally, on our implementation challenges, as I'm wrapping up here, discrete versus open fields in the EHR has caused some issues for us right now, where not all EHRs use the discrete fields that kind of deconstruct, the dose of the medication, the route of administration, the times per day that the medication should be taken. It's actually it's our benefit for EHRs, like most recent versions of like Epic, for instance, and others, where the fields are discrete. What we're really trying to focus in on, the real myopic piece here, is how do we focus on the times of day, and have it as morning, noon, evening, and bedtime, and not twice daily, hourly, et cetera, at least for the chronic medications. The confirmation of appropriate UMS mapping is a tedious task where we have to verify within the prescriber monographs, and that's something that's taken us a little bit longer working with Oak Street, because that's something they really, really wanted, this ability to auto-populate the UMS. That means we need to know what medications have no recommendation in the monograph, what time of day it should be taken versus what drugs are morning meds or bedtime medicines, et cetera. And the EHR build of the medication list and the auto-population is just, again, it took a little bit longer, just because some of the EHRs are not, the medication list is a bit more fixed. But again, if you take the time, it's a one-time cost to make the modifications. And I think that's the big sell, is getting, having the data say that if you give it information to them in this manner, they'll be able to, it'll translate to better adherence. And another aspect I didn't mention too much is we've also, at Oak Street's request, we're helping them use an existing text reminder appointment system that they've been using to, again, make sure patients knew when their next visit was, and to leverage that to actually map it to the UMS and give them text reminders on when to take medication. And right now, that platform has been built, but there's a few manual aspects to it that we're still working out. I'm going to stop here if it's okay, just due to time, and see if there's opportunity for a few questions.
Mike, thanks so much for that presentation and sharing how the UMS is addressing issues around health literacy and medication complexity that we know so many patients face. Just a reminder, Q&A icon at the bottom of your screen if you want to submit any questions. Here's one that has come in. Have there been any efforts to deprescribe and simplify some of the medication regimens?
So on the deprescribing question, so that's a fantastic one. In fact, we personally have not been focused on the deprescribing aspect of for the medication regimen aspects, although I think that is a nice complement to the activities we're trying to work on. We have some colleagues at Northwestern that are very much geared towards that, especially in the older adult populations. Groups at Johns Hopkins and at University of California, San Francisco have been long doing this. So I think it's a complementary kind of task, and it should be done. And I think creating opportunities, whether it be through a medication review, and I can even talk a bit more about some other activities, but even like what Carrie was talking about and earlier, where how do you bring the pharmacist in so they can be proactively looking at what patients are taking and working with as a care team with prescribers to really kind of think about what medications might actually be more of a detriment to their adherence or even to the patient's safety, rather than providing any benefit towards, you know, a treated condition. So for us, it's just been about organizing the medications that they're currently taking, but I think that's a great direction that it should be coordinated with a deprescribing effort.
Thank you. Next question is, how did you affect the changes for UMS into the EHR? Did you work directly with the EHR vendor, and who incurred the cost of that enhancement?
So for us, and we've been doing this, and so this project with Greenway, and it kind of gets to, you know, me underscoring just how fantastic we feel so fortunate to have been able to work with Oak Street. Usually when you get the so we have been in conversations with some EHR vendors, and also some of the software platforms that kind of provide the prescribing medication information. And it's actually, to be very direct, it's the cost and the time and the effort is incurred not by the EHR vendor, but actually by the health system. So every health system will have an informatics team that is managing their EHR. At Northwestern, we've been long working with we have an Epic Innovations team. We use Epic EHR. With Greenway, we sat down with them when this project got launched. We sat down with their informatics team and kind of helped draw up the architecture, and we fitted into the parameters of what they were able to do and what they also clinically wanted to do. And some of these things are very basic. So this is not, I would say, a sophisticated build, but it did require having a very willing partner that was, you know, wanting to see the benefit of it, and they saw the benefit clinically for their patients, and they also felt that it was a sizable lift that they could manage. Just as, I mean, it is something that I would say most healthcare systems recognize that you know, EHRs out of the box require considerable tailoring anyway. So this and these are not very complicated. We've purposely tried to do some of the builds to not be too overly complicated due to the effect on the scalability of it.
Thanks, Mike. We are actually almost at time here, so just want to say a huge thanks to you and also to Carrie for all of your insights and for all the questions you fielded, and also to all the participants for posing such great questions today, and of course to the Gordon and Betty Moore Foundation for their support of this initiative. We'd like to ask everyone to please just take a moment now to complete a very short survey that will pop up on your screen and provide us with feedback on today's webinar. The slides and webinar recording will be sent to all the participants tomorrow. And thank you again to everyone for tuning in today. Please visit chcs.org to learn more. Thanks and have a great afternoon.